All right. So welcome. I was wondering, what is your name, title, and what is your focus in medicine?
Sure. So my name is Amit Rushi. I'm the Chief Commercial Officer at Bodyport. We're a biomarker guided digital therapeutics company. We're focused on complex chronic conditions. We are beginning ready to launch our debut product, the Bodyport for Heart Health Solution, where we're going to be tackling folks diagnosed with heart failure and really helping remediate the gap in understanding how their heart function and fluid status is worsening, which leads to about 1 million hospitalizations a year. Dominantly, about 90% of those hospitalizations are due to unknown fluid accumulation. So our solution is geared towards making it super simple for the patient to create the longitudinal biomarkers and solve for their clinical teams accessing those longitudinal biomarkers that represent their heart function and fluid status. So as those numbers change, as their congestion parameters worsen, we're able to enable the right alerts and triggers to their clinical teams so that they could intervene earlier in activities, medical interventions such as a remote oral diuretic titration, a scheduled IV diuresis, or if needed, they can bring in the patient for a in-clinic diagnostic or a more critical clinical encounter to alleviate the issues. But ultimately, right now, with 6 million folks in America living with heart failure and 1 million hospitalizations a year, all these worsening conditions are realized too late. And we're trying to make sure there's the simplest way for the patient to take that simple daily step using our cardiac scale and produce these biomarkers so that these early signals can be detected and less severe clinical encounters can be activated.
Thank you. So you mentioned this is namely for diagnosis and early intervention, early treatment of cardiac failure. What was done in the past to diagnose, hopefully prevent, but diagnose and then treat these conditions?
Sure. So we're not involved in the diagnosis of the patient to diagnose them with heart failure. Our solution will be used on patients already diagnosed and living with heart failure. But their standard of care for managing these patients was based on several simple things. This is considered best practice. When you are diagnosed with heart failure, you typically discover you have heart failure when you get admitted to the ED, and they have to ascertain what's been going on with you. They'll realize that you actually had a heart event, and they will see that your heart is not functioning as effectively and efficiently as it should be. And so while you're in that ICU 7 to 10 or more days, they will understand that you have too much congestion. They're going to try and remove that excess fluid from you. And once they feel you're stabilized, they have identified you at the dry weight. Now they call it a dry weight because you're not over congested with excess fluid. And the dry weight means that now they know that you're, let's say, at 205 pounds, your vitals are stable in the ICU, we can discharge you. And now we're going to ask you to go home and weigh yourself daily. And if you're going to, gain a few pounds in the next in 2 or 3 days, give us a call. This is the heart failure team at the hospital that discharge you. And then over the phone, that nurse will go ahead and do a clinical assessment of like, how are you feeling when you lay down flat in your bed? Is it hard to breathe when you walk upstairs? Are you short of breath, etc. They'll do a basic assessment of you with those types of symptoms over the phone. And if they feel that this is within the norm and may self-resolve, they'll ask you to keep tracking your weight and call them back again if you feel any further symptoms. But if you gain 5 pounds in those 3 to 4 days, they want you to go straight to the ED because now you've gained too much weight, and they believe that weight gain is congestion. And this is a standard rule of thumb and kind of gets reset every week. And what they're doing is taking anyone's weight scale at home and saying, hey, weight gain with a heart failure patient is more likely going to be fluid than not. We've already told them to live on a low sodium diet. We told them to get a little bit more exercise, like a 10-minute walk after at least 2 meals a day, and just be more cognizant of changing their lifestyle to live healthier, to try to offset the demands on their less efficient heart so that they can try to normalize. Um, it's challenging. It's challenging to, when that patient's not being given a weight scale, it's challenging where the patient is not seeing a clinical feedback loop by their medical team. Saying like, I called you, you told me to do nothing, keep taking my diuretics as prescribed before. So we still end up, unfortunately, where 6 million folks living with heart failure, 1 million of them still get hospitalized a year. What we ended up doing, my founders, Corey and Sarah, really remarkable biomedical engineers, they actually really focused on that gap, that gap of understanding the patient's true health status remotely in order to better inform the clinical team of something that's happening, of a more serious understanding of what's happening to that patient. So they worked really hard to take the real estate that's supposed to already be in that patient's home, a weight scale, and add in a lot of complex sensors with algorithms that would actually yield the biomarkers of heart function and fluid status. So certainly body weight, adding pulse rate, being able to arrive at a fluid index, and in our pipeline, going to cardiac output, systolic, function, et cetera, to get this holistic assessment of the patient every time they step on the cardiac scale. And with this longitudinally, we're able to present back to the medical team on an alert basis the distinguishing characteristics of soft tissue versus fluid. And now you can actually create a more informative assessment of the patient's fluid status and set a rule that, okay, I need to be notified. You can say standard of care weight-based changing, weight-based changes, and you can add to that fluid changes. And we call that euvolemia. That's where we need your fluids to be. But if you're in hypervolemia, we need to act on that. And that's relevant to understand appropriate titration of your diuretic, which helps remove fluids from your body. So that's what we end up doing is we track the changes in your heart function and fluid status and set those clinical rules customized to your clinical team, of course, so that they can understand when something's going to a certain level of fluid in the patient, and they can take an action that's more simple. And that's could be a non-medical intervention of, let me get you coached on understanding that you ate a really salty food. One of our examples are folks who say like, hey, I saw my fluid level, change on my cardiac scale, my weekly report email from Bodyport. I know that I had, Panda Express and it was really salty. I've been told that. And I see that change. I see that it was in there, and my weight didn't change that much, but I saw that my fluid went up. And that's a learning moment that helps them adopt that living healthier lifestyle that be encouraged to, low sodium diet, overall food adjustment. But then if there's so much fluid accumulation over a number of days that hits a certain rule, you're going to need medical intervention. Now, being told, come to the ED, get admitted, and then what you end up getting is a unscheduled IV diuresis. So you're on a bag for four hours. You're going to go urinate, a few times during that. You might remove 20 pounds of fluid. You should never arrive at that stage of clinical encounter. It should be more incremental and avoid the need for an unscheduled IV diuresis. The only way you can arrive at that is you have an understanding of the patient's fluid accumulation over time and you intervene earlier. That's what we solve for. That's what we track, and we end up solving for the opportunity, the window of which you can intervene in a less severe clinical encounter approach. Now, just to kind of extend this from that clinical unmet need and how we took a patient-centric approach to create the clinical longitudinal biomarkers, asking the patient to take one step a day and interrogate their lower body to assess their fluid volume, et cetera. That's great. We made it simple. No wearable will beat that simplicity. You're asking them to step on something. You don't need to worry about skin irritation, adhesion, enough contact, all that kind of stuff. But on the clinical side, you're talking about a health system. And what I mean by that is an integrated delivery network or an ACO, those who offer their insurance to the members. So they're fully at risk with the patient. They do care about optimizing all their clinical encounters, or a hospital, which doesn't offer insurance, and therefore they're in that fee-for-service world. We need to understand their incentives, how their businesses work. And there's no judgment here. These are just how those businesses work. And we have to figure out how to bring our innovation into adoption in their reality. And let me start with the hospital. In a fee-for-service world, it's really challenging to drive value-based care, where you basically want them to operate like an ACO or IDN. So we need to understand, how can they look at this from improving the care of their patients while still running a robust business. And there's, opportunities to leverage remote monitoring codes, by which they are actually, these fee-for-service physicians in the clinics and outpatient facilities are actually paid to remotely monitor these patients. And you figure out how to fit into those billing codes and the frequency of that. And then you're able to drive the adoption of your innovation. And with the adoption, you can lead to the improvement in standard of care for that hospital sector. Now, for an IDN or ACO sector, they are incented to reduce the hospitalizations, and they are incented to reduce, where they can, the high cost clinical encounters, and instead do lower cost upstream clinical activities to reduce the overall downstream impact. And from that perspective, really looking at, evolving their protocols with their team members, so that they do react to these alerts that we provide, again, configurable by their team, so the sensitivity of those alerts, drive their appropriate medication, pharmacotherapy adjustments, even include diagnostic, adjustments to their care protocol to, I really identify if there's another underlying issue with the patient, such as a valve deformity that wasn't realized before. And they're able to act on that and, try to reduce at a population health level, the overall spend in this population for higher cost clinical encounters. So that's how we know how to address the need for a self-sustaining, in terms of a revenue generation need for a fee-for-service environment, but also a cost savings orientation for an IDN ACO environment. And really all centered still in our mission of advancing the standard of care for the management of all heart failure patients, regardless of how close they live to a top-rated academic medical center. Because it doesn't matter if you're in Idaho, where I grew up, or you're here, right next to Cedars-Sinai, number 3 heart center in the US. And, you should not have to look at your zip code, your proximity to such facilities, and your insurance access to believe you'll get the best heart failure management. Any clinician that's got our solution deployed should always know your heart function and fluid status and understand the clinical protocols by which they can optimally manage you. And that's what we believe we can eventually democratize and, bring that, if you will, equity to anyone living with heart failure and any clinical team member managing those patients.
So you mentioned fee for service and ACO. So these are different hospital sort of payment systems. Can you elaborate on what those mean?
Yeah, so from a hospital basis, an entity that does not carry their insurance, just for comparison, Kaiser is a closed loop system. You can only go to a Kaiser if you are a Kaiser member paying their insurance. So they are incented to try to be very proactive with you. One example here in the LA area, there's only one Kaiser hospital that has an ED. Everywhere else, they prefer you to a partner a hospital that has an ED, because they invest so much on proactive care. They have proven that far fewer of their members need to go visit the ED. In a regular hospital with no insurance being offered through that hospital or a collection of hospitals as a health system, they make money, to put it very simply, by charging for procedures. And that's called a fee for a service they provide, fee for service, FFS. And when you look at a physician clinic, you multi-specialty clinics or large cardiology clinics, these are independent practices and they are fee for service oriented. They're not going at risk with the patient population they manage versus a contract they have with an insurance company. Going at risk means that, let's say, $100 million is what they'll get to manage their entire patient population of 25,000 patients living with severe chronic conditions, just spitballing here. That $100 million gets spent however they see fit, but that's all they're getting. So they're incented to be highly efficient with that. And that means they're trying, they should spend that money to avoid the severe clinical encounters. I'm defining severe as something that requires a surgical intervention, something that requires a hospitalization or multiple days of a hospitalization and really expensive teams. The most expensive care is always when you're in the hospital. So if you're going at risk or a health system that has insurance, you want to go chase, or I should say allocate resources to the least expensive care. So you actually mitigate the propensity of a need for expensive care for your patient cohorts. So that's really how you distinguish fee for service versus ACOs, accountable care organizations, or IDNs, integrated delivery networks. Both an ACO and IDN actually has that insurance component to it, where that entity of healthcare delivery organizations is incented by the nature of their business model to reduce the high cost care and instead, increase their margins by going into lower cost care.
Thank you. And so what do you find has been the most major challenges to convince, you mentioned a lot about the hospitals, but not just the hospitals, but also the patients to adopt this technology to perform this sort of at-home integrated care?
Yeah, no, I love this question. So we are pre-commercial. It's February 2022, but we are going to be launching this spring. And in our pilots and studies to date, one thing is very clear from a patient point of view. This is simple. If you're going to be involved in chronic condition management, just to let you know, chronic conditions account for 70% of our US healthcare GDP. 70%. Healthcare accounts for about 20% of the overall US GDP. So it's a gigantic number for chronic condition management. And chronic condition management does not mean they're living in the hospital all year long. So that you need to actually help support the patient where they are, which is at home, going to work, somehow fitting into their lifestyle. And our design, really insightful founders. It's their second, startup. So they did really well the first startup, and then they, took that experience even further, going to the proactive side of medicine. They started with the design, architecture, everything centered on how the patient can most easily adopt this solution. And then they said, this would be a cardiac scale in their home. Now, how do we take that real estate and make sure it generates clinically acceptable biomarkers for the medical team to act upon? That was an incredible technical challenge. And it's a blend of technical and clinical. So going through the technical feasibility for years, and Corey and Sarah brought Bodyport, our company, through Y Combinator and then also Rock Health. But they worked through the technical feasibility through these incubators as well, and then getting to clinical studies for validation of that and iterated this. And they've made sure to publish the evidence at all times. And this was before my time, so I'm just reflecting the great work that they and their early team did. And this allows to solve for the patient adoption. And it's been such great feedback that it's simple. I've worked in the diabetes space, glucose sensors, insulin pumps. I've worked on trying to put a wearable patch on a dialysis patient. And I've been around tons of other innovations where you're trying to capture medical grade metrics from a patient's body outside of a hospital. And it's super challenging for so many, if you will, on-body burden thing where someone living with heart failure, they go to bed, they wake up the next morning, they hit the head, brush their teeth, step on our cardiac scale. In a short while, about 20 seconds, it vibrates, letting them know that they're done with their reading. They step off the scale, they can get on with their day. They can go shower, get ready for getting to work, etc. That's the kind of feedback we've heard from patients. It's simple. Now, on the other side of the table, the medical teams, our clinical interface is a clinical portal that presents the dashboard of the patients, It gives them their ability to drill down on patients, see the alerts, and has a workflow that actually has been optimized by over 100 nurses and cardiologists that have given this feedback. And for them, they have to first believe in the biomarkers. So our evidence first, publication always approach, enable them to believe in that. That's hard work to get to that point. It's really challenging. Second, this is still novel. A fluid index on a patient captured from a home has never been done before. So being able to see this, relative to their history of patients who actually got hospitalized, stabilized, as I mentioned before, by removing their weight and getting them to a dry weight, and then seeing that corresponding value in our cardiac scale was a level of proof that enabled the medical teams to see and believe in the values we provide. Now, closing that loop between the patient being compliant, taking that daily step, and then the medical team seeing the, if you will, volemia excursions and getting back to euvolemia and then staying in hypervolemia for too long, and then them doing a medical pharmacotherapy adjustment and then seeing the corresponding drop in hypervolemia into more acceptable euvolemia ranges. All you're doing is a virtuous feedback cycle now, where they can now rely on what we're providing, and they see that they're able to remotely monitor this patient and manage the patient. So stunning design choices by my founders, really complex, both hardware and firmware and biomarker AI-driven challenges that they had to overcome to yield these biomarkers that were on the cusp of the FDA clearance and then the acceptance by the medical team. So I really consider myself lucky to have joined this team where this solution is, first of all, a wow factor for any clinical team that we go to and talk to. Second, from a patient perspective, they're just amazed that their medical team can know so much about them just by that series of steps, daily morning steps. So that enables the patient to be open to understand changes in their health status, their heart function and fluid status, that they can ultimately change. And we really hope to empower the patient over time to understand how to manage their health themselves better, much like someone with type 1 diabetes can look at their own glucose value and titrate their own insulin. A drug, if misused, can kill you. Titrate their own insulin to satisfy the needs of them living with type 1 diabetes, all self-sufficient on a daily acute basis. We hope to arrive in that similar fashion, not as acute needs, of course, as someone living with type 1 diabetes, but on a daily, not hourly, but a daily and a weekly basis, a lot of self-learning that can go right to the patient and ultimately help them live healthier. So that's what we're focused on.
Very nice. You mentioned that you worked on several other different chronic condition management, devices. What made this kind of stand out? You mentioned a few things like how simple it is, but what made this stand out so much more than those other devices? For instance, a lot has been done in diabetes and wireless health management that makes this much more successful and much more adoptable, right, to say our patients.
Yeah, that's a great question. I consider it's a bit of a matrix, acuity versus what degree of accuracy and value. So in the diabetes sector, I'm a big fan of the innovation there. Getting to factory calibrated CGMs was such a big deal. And that happened, during my final year in the diabetes world. And that enabled less devices to be carried around by folks living with diabetes that have CGMs. The patient satisfaction where you can be equipped with tools that really suit your lifestyle is tremendous. And the accuracy on these devices relative to the BGM, if you will, single digit MARD values, was a challenge for all three major players. There's more innovative CGM or CGM-like solutions coming out there. Some players coming out with microneedle-based sensors that are half the depth of placement into your interstitial fluids. Think of like a Nicoderm patch, essentially. Adding more analytes to that, so not only getting your glucose, but maybe also lactate and other values, ketones, et cetera. So there's still a tremendous amount of innovation to be had in there. driving the adoption into the overall space. There's still more room to grow, and going into late stage type 2 market, of course, too. So I think that's exciting, and I'm really excited that it finally, I think it was in 2016 or 2017, remote monitoring solutions for diabetes gained monthly remote monitoring reimbursement. So find the business model caught up to that, which can spur further adoption. Tremendous. That's great. In the dialysis sector where I work, it's a very challenging situation. 8% of the CMS population is on dialysis. Yet, 2% of the CMS population is on dialysis. Yet, they account for 8% of the overall CMS budget. So managing someone on dialysis, getting their critical biomarkers is a super challenge. But they have a whole host of other comorbidities to make it very challenging to optimize their health. But the innovation in that field has been tremendous, where there's been a movement to create home hemodialysis machines. And if someone crashes into dialysis, they're trying so hard to start them on home hemo, because when you're in the comfort of your own home, it has been proven again and again that the patient improves their health better if they have the right support at home. So the innovation of bringing those in-clinic solutions, the dialysis clinic solutions, or for some hospitals, dialysis within a hospital, bring that to the patient's home. It's been great innovation to witness and see the improvement in these patient populations. When I look at Bodyport, when I was considering to join them and going through a very heavy due diligence on my part, looking at clinical study design, engineering validation reports, publication, manuscripts, et cetera, I was just so impressed with the robustness of the founding team of understanding medical device product development and clinical viability, understanding what it took to prove that not only can we create this, but it's also clinically acceptable, meaning a clinical team can act on the information coming from this, not just statistically, okay, it's there. It's so powerful enough that they do believe it as useful and cognizant of this represents this patient's health status, and I'm going to act on it. So that was really robust. And I do, want to reiterate the design. I've been through the wearable space. I'm talking FDA class 3 device wearables, and not my Apple Watch, not consumer wearables. And they're great, high utility and need, but they present, the introduction of them presents other issues that need to be supported and addressed. So they present enough value for the patient to still use them, but the company to actually add more resources to address, we'll send you a replacement patch, or we notice that you were wearing the patch, but it looks like it's loose. Can you put some over tape on it to make sure it's adhering to your skin appropriately? So when there's enough value, a type 1 diabetes patient needs to know their glucose number, a couple hours before they go into their lunch, and the next 2 hours post lunch, so they can go ahead and get themselves more insulin or give themselves some glucose tablets, etc. You need to know this. So there's value in the value trade-off of those other issues versus me knowing this information when I need it. When you look at heart failure, or should I say heart disease, the realm, we're not doing AFib detection. The realm of, managing trends and trying to drive change in patient behavior and helping the clinical team know when to optimize medication management earlier. That is something that is not a, hourly acute need. That is a daily, weekly opportunity. And so this solution was so well designed to address that. And more broadly speaking, we're starting in heart failure, but the adjacency of kidney disease for our solution is tremendous. And that represents a patient population size of 30 million people. And our opportunity to go upstream from heart failure, let's go all the way to hypertension. Now we're looking at numbers of 100 million people. And again, the simple real estate in the patient's home, from which we can keep on through our algorithm development, getting more biomarkers in play. And we're working on that blood pressure biomarker that many others are trying to address as well. But there's so much we can do with what we've created as that singular piece of real estate in the patient's home. So for me, the immediate focus of getting to heart failure and making an impact and growing from that impact into adjacencies like kidney disease, upstream in heart disease, and what I will call, and what has been called by many scientists, the cardiorenal metabolic sector. where the interplay of these three organs have to be understood and can be optimized if you can understand them. So, it's a tremendous opportunity over the long run, and again, all with really remarkable innovation by my founders.
Very nice. Just to help define real quick, you mentioned CGM and CNS. Maybe you can help define those acronyms.
Oh yeah, so CGM, continuous glucose monitor. I don't know if I said CNS, but central nervous system. I had worked in the epilepsy market before, but that was on the drug side. But yeah, CGM, instead of pricking your finger with the blood glucose meter, or BGM, to get a glucose value of one data point, a CGM is actually inserted into your obliques. It's just going down about 4 millimeters for the sensor length. And it stays in there about 14 days. And some sensors, I think, can go up to 21 days. And it'll provide a glucose reading every 5 minutes. Or I think with Abbott Libre, you can get a reading every minute. And getting to know your glycemic variability throughout, if you will, 5 minutes, every 5 minutes, that's 288 readings in a day. It is so informative and lets you tie your body's response to certain foods, certain time of day, certain stress levels, et cetera. Really helps to inform the picture by which you can help optimize what you need for insulin, what you need for glucose, again, if you're living with type 1 diabetes.
Thank you. And so you mentioned you see this in the future going even to things like kidney failure. Where do you see this going sort of in the future, and what improvements need to be made in order to get there?
Yeah, so I mentioned chronic kidney disease. So that's stages 1 through 5, which is preceding end stage renal disease. That's kidney failure.
Mhm.
So kidney failure, you're on dialysis. But preceding that, you can be well managed to help prevent yourself from going on dialysis, which is something everybody wants to make sure, even the patient themselves, not to get on dialysis. And when you talk about your kidneys, you're talking about fluid management. You are getting a compromised kidney function, and the more compromised that gets, let's say you get stage at 3B, and you're now at a certain GFR level, that's a clinical metric, globular filtration rate. I can't remember the exact name of it.
Thank you.
But the bigger point is there's already clinical scales for matrices from which you classify and stage a patient for kidney disease. And when you're already at 3B, that's where there's the best opportunity to get these patients onto a kidney disease program, get them onto a kidney-friendly diet, lifestyle change, really support them, because now they are on that road, the downhill road, progressing to kidney failure, which I mentioned this. Those on dialysis represent 2% of the CMS population, Medicare, Medicaid population, but they account for 8% of the overall budget. It's incredibly expensive and a very low mortality once you're on dialysis.
So again, CMS is chronic management system, right?
Centers for Medicaid and Medicare Services.
Center for,
Yeah.
Sorry, we have to define acronyms.
No worries. So yeah, Medicare and Medicaid, that population where all the huge amount of budget for our GDP goes for healthcare spending. So yeah, the chronic kidney disease, CKD, stages 1 through 5, and once you're in stage 5, you're going to be put onto dialysis. Now you've officially entered end stage renal disease. If you're living in end-stage renal disease, you're on dialysis. You need a machine to filter out your blood and put it back into you. And it's a very difficult life. For our solution to be able to play in this cardio-renal metabolic space, where we're starting in heart failure, heart disease at large, knowing that the overlap of comorbidities with kidney disease is tremendous, and with diabetes is tremendous. And therefore, the interplay of all these conditions is really important for us to play a role in. And especially for heart failure and kidney disease, our ability to ascertain that patient's fluid volume and the changes in that helps their medical teams better optimize medical management, diagnostics, interventions, but then also better informs biomarker guided coaching, non-medical interventions to keep them on, if you will, on a certain pathway to improve their life, to live healthier, and tries to keep them staying on that, because we all know it's hard to change habits. You're going to slip up, but there's opportunities to get back up, because when you'll get into hypervolemia, for example, and the impact that will have. So use that learning loop to get you back on the right path.
Very nice. So if this was 10 years from now and your company has grown, what other improvements, or at least business model changes, do you think
Love
would
this
you
question.
envision happening, or that need to happen,
I
right?
love this question.
Get everyone on this.
Well, I mean, hey, you answered it for me. I could broadly speak of those folks living with hypertension to heart failure, those with chronic kidney disease, those with diabetes. I'm talking about 100 million people in the U.S. alone, and yeah, every single one of them should have a Bodyport for Heart Health solution, a cardiac scale, our cardiac scale, in their home, and that data needs to be gathered, and the longitudinal insights on this patient need to be understood and acted upon by their physician. Is it a heart failure specialist? Is it a nephrologist? Is it an endocrinologist? Is it a PCP? I would love to say 10 years from now, all the specialties, including advanced practice providers of PAs, NPs, physician assistants, nurse practitioners, and even PharmDs, that they're all able to utilize our system to then optimize the management and support of these patients living these conditions, and that these patients eventually are able to use their own clinical feedback loops, these biomarker guided interventions from us to keep themselves healthier. I will also say this: American College of Cardiology, ACC, American Heart Association, AHA, they always release joint statements for guidelines on heart failure management, guidelines on all sorts of heart disease management. Really looking forward to the day where we present real world interventional evidence and be able to demonstrate that those guidelines should be updated to include fluid index monitoring and management. And they have done that before. In the fall of 2021, they included coronary artery disease guidelines. They include in those new guidelines the addition of CT angiography with using a company's technology called HeartFlow, because of just reams of evidence demonstrating that using their AI interpretation of CT angios, they're able to better stage patients who are at risk of coronary artery disease or are officially living with CAD, coronary artery disease, and a management plan for those patients. So presenting more information from which clinical teams can stage a patient, understand what kind of plan of action to put for that patient, becomes so important that they become standard of care. They officially become guidelines. That's something I would love to see in the future. And of course, moving beyond that, you talk about new business models. Being able to create new reimbursement code for our prescription digital therapeutic. It's a new field under the FDA, and then the payment mechanisms for that are evolving. So I definitely believe that within the next 5 years, so by 2027, there would be a great opportunity for Bodyport to partake in those new business avenues, so that we can drive further adoption and recognition of the value we provide.
Thank you so much. Do you have anything else you want to mention before we head out?
I just want to emphasize, I did start out as a biomedical engineering student going to USC, and then 2 years into it, I switched to the business side. But all these innovations have been part of for this huge problem of chronic condition management. Chronic conditions account for 70% of the U.S. healthcare GDP. And of course, U.S. healthcare accounts for about 20% of overall U.S. GDP. So chronic conditions are a huge outlay of expenses for us. They involve so many innovations to understand what's happening to the patient's health status, be it its mental health, be it its diabetes, cardiovascular disease, et cetera, kidney disease. They require an understanding of the patient's clinical parameters away from a hospital. The whole point is to reduce the number of visits to hospitals, reduce the number of visits to a doctor's office. And I've worked with amazing biomedical engineers, especially here at Bodyport, that know how to tackle those problems and create those solutions. So, keep on encouraging anyone who's interested to pursue this pathway using engineering to solve for some of these biggest problems that really challenge our economy, but most importantly, are hugely challenging for patients and their families living with these conditions. The route through, biomedical engineers, those, data scientists as well that create these algorithms from the smallest amount of data, but that are validated clinically. Hats off to them. It's a worthy pursuit. It makes a huge impact, and it really is transforming how health and care, as some others put it, is evolving. And so, just want to leave that as a final note, saying it's really great work from any of your students that are pursuing this pathway, and many others non-engineers deeply appreciate their innovation.
All right. Well, thank you so much.